So our first speaker today is Dr. Leslie Cloud, and she is a neurologist with the VCU, that's the Virginia Commonwealth University Medical Center in Richmond, Virginia. She's a clinician investigator researching novel therapeutic approaches in the treatment of PD, including gastrointestinal symptoms, deep brain stimulation techniques for treating dementia, and vibration therapy to overcome freezing of gait. She's a graduate of the Medical College of Georgia School of Medicine. She did her internship and residency at Emory University, where she earned a master's degree in clinical research. I sure hope I've got all this right. She's highly regarded by her patients and colleagues. She's published extensively on Parkinson's disease, and I absolutely love the title of her presentation, No Guts, No Glory. Dr. Cloud.
Hi, good morning, everybody. Can everyone hear me? Okay, great. So, number one, thank you for having me here today. It's a pleasure to be here to talk to you about gastrointestinal symptoms in Parkinson's disease. And thank you for the very kind introduction. I'm a movement disorder specialist, and I have a clinical and a research interest in these GI symptoms. I should probably open with a little bit of a disclaimer or an apology. We're going to talk about all sorts of things that you don't normally talk about in polite society. And I'm just happy that you're not eating breakfast, because that would make that even more awkward. But if you embarrass easily, I'm so sorry. Okay. So it turns out that there are a variety of gastrointestinal symptoms that can occur in people with Parkinson's disease. The spectrum of GI symptoms spans the entire GI tract from top to bottom, pun intended. And while there are more than we can possibly talk about in the context of our talk today, the more common ones are listed here, and we're going to talk about each one of these individually. We're going to talk about what you can do if you have them, and we're going to, at the end of the talk, focus on why these GI symptoms are important in a larger sense, so what they might be able to tell us about what causes Parkinson's disease and why they're a topic of interest right now in the research world. So, why should we all be concerned with GI symptoms? So, for starters, we know that they negatively impact quality of life. Anybody who has ever suffered from any of these GI symptoms knows that they're quite annoying. They can also be associated with somewhat serious and even rarely life-threatening complications. For example, folks who have difficulty swallowing are at risk for aspiration pneumonia, which can be a very serious infection. Folks with severe constipation can be at risk for an intestinal obstruction and even rarely a perforation, and that can be a surgical emergency and can be life-threatening. So these can have real serious ramifications. They are actually, I think, the 5th or 6th most common cause of hospital admissions in the Parkinson's population. So they have economic, ramifications for healthcare costs. And then last but not least, they can affect other Parkinson's disease symptoms. And so the classic example is that when folks have slow stomach emptying, which is common in Parkinson's disease, it may cause you to absorb levodopa erratically. So one dose may get absorbed well and work quickly and work great, and then the next dose may take a really long time to kick in or may not kick in at all and therefore not work very well. And so if you have slow stomach emptying, it has ramifications for your motor symptoms as well. So these symptoms have far-reaching consequences. So we're going to start with weight loss. So weight loss is extremely common in Parkinson's disease. Women seem to be a little bit more vulnerable to this than men, but it happens certainly across both genders. We think the cause is probably multifactorial, and some of the main causes we'll talk about. So we know that people with Parkinson's disease often have an impaired sense of smell. If your sense of smell is impaired, your sense of taste is also impaired. And so if food doesn't taste as good as it used to, you may just be less interested in eating and you may take in fewer calories. Also, people with Parkinson's often have trouble swallowing and therefore may be a little bit more cautious and slow with eating. And I think we all learned as children, if you eat slowly versus eating quickly, you tend to take in less food because you feel full sooner and you're sort of more mindful when you eat and you tend not to eat as much. We know that you burn calories all day if you have involuntary movements like tremor or dyskinesia. And if you're burning calories all day, it can become hard to just keep up with those caloric needs. And then side effects of medication are often a contributing factor. A lot of our medications, like levodopa and dopamine agonists, cause nausea and anorexia as a side effect, and so that can play a role. And then lastly, as the disease progresses and people become more immobile, you have loss of muscle mass, and that can really contribute to rapid and significant weight loss. So typically we say you're allowed to lose about 10 to 15 pounds over the course of your disease without us getting too worried that there's something else going on. But if you have weight loss that is dramatic or that's ongoing, and certainly if it's above that 10 to 15 pounds, and also if you are significantly underweight, period, then it is a concern and it really can't be ignored. So typically when we feel like we really need to intervene, the first thing to do would be to consult with your primary care provider to make sure that there's not another medical condition that's contributing. And if nothing is found, then the next most appropriate step is a consultation with a registered dietitian to really look at what your caloric needs are to maintain your weight and to stave off further weight loss, and then to really look at what you're eating and help you figure out how you can better meet your caloric needs. So that is generally how we approach weight loss. So we're going to move on now and talk about drooling. So many patients with Parkinson's disease have a feeling of just having too much saliva in their mouth, and if it becomes enough of a problem, then you can get overflow or drooling. This happens sometimes early in the disease, sometimes it worsens as the disease progresses. It is socially embarrassing, it's annoying, it can lead to problems with poor dentition, and in a worst case scenario, it can contribute to aspiration pneumonia, which we'll talk about a little bit more in a moment. So interestingly, when we have studied saliva production in Parkinson's patients, it's not increased as you might think, it's actually decreased. So the reason for the excessive saliva in the mouth and the drooling is related to swallowing. So we all normally swallow automatically all the time, and that's how we manage our oral secretions. But folks with Parkinson's disease don't swallow as often or as efficiently or as well. And so as a result, that saliva builds up in the mouth and it pools, and eventually you get overflow and drooling. So when you're not managing your oral secretions well, it's possible that they could go down the wrong way and go down into your windpipe and lead to an aspiration pneumonia, which is very dangerous. It turns out that our mouths are filthy and they're full of bacteria, and if that bacteria gets into the lungs, it's a real problem. So the good news is that there are many, many things we can do about drooling. This is one of the GI symptoms that we have a whole arsenal of things that we can use to make this problem better. So I usually tell folks if it's mild and it's just a social embarrassment issue for you, sometimes if you just are chewing gum or if you have hard candy that you can put in your mouth when you're in social situations, that will just remind you to swallow more frequently. And that will help sometimes if it's a mild problem. If it's more severe, we have lots of medications that we can use to treat it. And I won't get too much into details here, but just to let you know, many of these are topical medications that you just apply in the mouth several times a day, and they just help to dry up saliva for a few hours at a time. So for mild drooling, that might be all you need. When that doesn't work, or for more severe drooling, we have oral medication that you can take that perhaps has slightly more risk of side effects, but generally is safe and well tolerated. And if that doesn't work or isn't well tolerated for more severe drooling, we can do botulinum toxin injections into the salivary glands here and here. It's a quick office procedure, less than 10 minutes. Most movement disorders neurologists can do that. If not, they can certainly refer you to an ears, nose, and throat doctor who can do that in the office. And that will very effectively dry up secretions for months at a time, so that's a really nice way to deal with it if you have more severe drooling. So we'll move on and talk about difficulty swallowing. So this is also very common in Parkinson's disease. It's interesting because if you take random patients with Parkinson's disease, regardless of whether they're complaining of swallowing problems or not, and you actually do specialized tests to evaluate their swallowing, we find that a large majority will have some problems with their swallowing function that they may be completely unaware of. So you can have some issues and not even know it. Oftentimes, however, you're aware of it because you're noticing things like coughing or choking or just difficulty when you're swallowing either liquids or solids or pills. And so it's important, certainly if you're noticing any problems, to mention that to your neurologist so it can be evaluated and managed appropriately. You don't want to ignore that because of the risk of aspiration pneumonia. So again, if your swallowing function is impaired, things can go down the wrong way, and instead of going into your stomach, they can go into your lungs, and that can cause an aspiration pneumonia, which is not good. So if you have swallowing issues, you really need to be referred to a speech and swallowing therapist who can do some specialized tests to look at your swallow function. The problem can be in the mouth, the problem can be lower down in your esophagus, and these specialized tests can help figure out where the problem is. And you could have a problem in more than one place. And the treatment is different depending on where the problem is, so it's important to have that evaluated thoroughly. And then a speech and swallowing therapist can also teach compensatory techniques that can help you be more safe with your swallowing. And if the problem is lower down in the esophagus, they can refer you to someone who might be able to help with that as well. Fortunately, it is only in very rare circumstances in Parkinson's disease patients that we need to think about something like a feeding tube. Most of the time, fortunately, we're able to get by with these speech and language pathology techniques and just working on safer swallowing. Also, sometimes optimizing Parkinson's disease medications can help, so sometimes your neurologist can help by just adjusting your medications. Okay, so we're going to move on and talk about nausea. So nausea is a common side effect of almost all of our medications that we use to treat the motor symptoms of Parkinson's disease. So sometimes this is our fault. Sometimes we do this to you with our medicines to treat your tremor or your stiffness or your slowness. But it can also occur in patients who take no medications for their Parkinson's disease. And in those cases, it's often due to slow stomach emptying. So slow stomach emptying is extremely common in the Parkinson's disease population, and it leads to nausea, it leads to feeling full too soon during meals or not being able to finish a normal-sized meal. It leads to bloating and sometimes abdominal discomfort or pain, and over the long run, it can contribute to weight loss. So, and we also briefly talked earlier about how slow stomach emptying can affect the absorption of Parkinson's disease medications. So if you have nausea, the first step is to talk to your neurologist to figure out what the cause might be. If it's related to medication side effects, then sometimes just simple medication adjustments can help dramatically. If we think it's related to slow stomach emptying and not to a medication side effect, then there are also some things we can do about it. So changing your diet in a way that can help is often very useful. So there is a special diet called a gastroparesis diet. Gastroparesis is the medical word for slow stomach emptying. And so this is a way of eating that encourages small, frequent meals. So instead of 3 big meals a day, take 6 smaller ones. Try to avoid foods that are extremely high in fat or fiber. You still obviously have to eat fat and fiber, but to try to spread it out throughout the day rather than eating too much at one sitting. Trying to take plenty of fluids during meals to help wash things down, and then remaining upright and active for 1 to 2 hours after eating rather than eating and immediately going and lying down in the bed. So sometimes for mild, slow stomach emptying, just those minor dietary tweaks can be enough to really help with managing the nausea. If that doesn't work and you need medication, it becomes a little bit more difficult because we don't have a lot of options for Parkinson's patients with slow stomach emptying. There is only one FDA-approved drug for slow stomach emptying in the United States, and it is not safe for folks with Parkinson's disease. It's called metoclopramide. And the reason it's not safe is because it gets into the brain and it works against dopamine receptors, so it can actually make the Parkinson's symptoms worse. So it leaves us with a difficult situation. There are a couple of drugs that are not FDA approved for this condition, but that can sometimes be made available, and those can sometimes help. And then for really severe or refractory cases, which are uncommon in Parkinson's disease, but they do happen, there are some very sophisticated, specialized things that are available often through a gastroenterologist, who is a doctor that specializes in GI problems. And so they can do things like use a gastric pacemaker or even use Botox into the sphincter at the bottom of the stomach to try to help things move along and empty out of the stomach. So there are things that can be done about it, but we do really need better treatment options. Just to spend a minute or so talking about this. So many people may have heard of a new type of therapy called Duopa, that is the brand name, but it's carbidopa-levodopa intestinal gel. The concept of slow stomach emptying and how that contributes to erratic absorption of levodopa is actually one of the main rationales for developing this therapy, this Duopa therapy, which bypasses the stomach and delivers the levodopa directly into the place where it's absorbed in the bowel. And so for folks who have really bad slow stomach emptying and therefore very erratic responses to levodopa, this Duopa therapy is sometimes very helpful and can sometimes allow you to even significantly reduce your total daily dose of levodopa because it just works better for people with very bad issues with stomach emptying. So that's how that fits in with what we're talking about today. Okay, so constipation. We're going to move on and talk about constipation. This is probably the symptom that I spend most of my time in clinic talking with people about as far as the GI symptoms go. Constipation is extremely common. Almost everybody with PD at some point in their disease struggles with constipation. Interestingly, it can occur very early, up to 10 years before the motor symptoms of the disease. So it can be part of that pre-motor period where people are starting to show some signs that they're going to go on to develop Parkinson's disease. Treatment typically ought to begin, I think, with a conservative approach that doesn't involve any medications. So I typically really look at people's lifestyle factors. How much are they drinking every day? If you're a woman, you should drink at least 2 liters a day of water. If you're a man, you should drink at least 3 liters a day of water. And so sometimes just getting enough fluids in can make enough of a difference. We look at how much fiber people are eating and are they really getting as much as they need. So for men over the age of 50, you should be taking in 30 grams of fiber a day. Women should be taking in about 21 grams of fiber a day over the age of 50. That's a lot of fiber. I don't know if any of you read your nutritional labels, but you have to be really mindful about what you eat to get in that much fiber every day. So again, sometimes just being a little bit more mindful about the lifestyle factors can make a big difference. Exercise helps because gravity, just sort of helps move things along. So increasing daily activity levels. And then having your doctor, either your neurologist or your primary care doctor, really scrutinize your medication list to make sure that you're not taking something for either your Parkinson's disease or another medical problem that might be contributing to the constipation. Sometimes things like your blood pressure medications will actually be working against you in the constipation department, and you might be able to make a simple substitution that can go a long way toward helping. So we always start there. If we don't get the results we want, then the good news is for this particular symptom, we have like a whole arsenal of medications that can help. And fortunately, in Parkinson's disease, we have a little bit of clinical trial data to guide us in how to manage the constipation safely and effectively. So typically my approach is if it's mild, I tell people to start with Psyllium, which is available over the counter without a prescription under the brand name Metamucil. And you can combine that with a stool softener if you need to. You don't have to. And the one that we usually recommend is Docusate Sodium, also available over the counter without a prescription under the brand name Colace. For mild constipation, those lifestyle factors and this is often all that's needed. If this doesn't work or if it's ineffective, you can buy polyethylene glycol. This is a stronger laxative that's also available over the counter without a prescription. And that, in most people, can be taken safely over the long term, and it's often very effective. If you've done all of those things and you're still having a problem, then you can consider prescription laxatives, and the market has really exploded over the last decade or so. We have a lot of new types of prescription laxatives that work in different ways, and so you can almost always find one that will work for you, so there's lots of choices there. I think the main thing to remember is that you always want to talk to your doctor before you buy an over-the-counter laxative, because there are some that are available over-the-counter without a prescription that are not safe for long-term use. They're all safe, generally speaking, for short-term use, but there are certain laxatives called stimulant laxatives which can be habit-forming, and you really don't want to take those every day for the rest of your life. So you want to make sure you at least discuss it with your primary care provider or your neurologist before you just go buy something and take it over the long run. Okay, so Last but not least, we're going to talk about defecatory dysfunction. So this is generally defined as a feeling of excessive straining, pain, or a feeling of incomplete evacuation during a bowel movement. It turns out that the act of defecation is actually really complicated. A lot of different muscle groups have to contract at the same time so that you can effectively push. At the same time, a lot of different muscle groups have to relax so that you can open up and effectively eliminate. So in folks with Parkinson's disease, sometimes those muscles don't coordinate the way that they really should. And so what ends up happening is that you are contracting ineffectively against a closed door. And it can be very frustrating and very uncomfortable. Unfortunately, giving things like laxatives or stool softeners does not help this problem. And in fact, it may just make it worse. And so we really often are in a situation where people get very frustrated and we don't have a lot that we can offer. There is a little bit of clinical trial data, small studies of just a few patients, to suggest that a medication called apomorphine, which is often used as a rescue medication for sudden off symptoms in Parkinson's disease, if you inject yourself with apomorphine at that first sort of call to stool where you feel like you might need to go, sometimes that can help to coordinate those muscles and more effectively have a bowel movement. As you can imagine, not a lot of people would be excited to have to give themselves a shot of a medication every time they want to have a bowel movement. So that's not really a great long-term solution. There are also some small studies to suggest that botulinum toxin injections into the right muscles using ultrasound guidance can help those muscles relax and do what they need to do a little bit more effectively. As you can imagine, that's an even less popular treatment option because there's not a lot of people that would be excited to get needles put there. But it is an option for people who are desperate. The thing that I have honestly found the most effective is working with a pelvic floor physical therapist, if you can find one in your area. These are very specialized physical therapists who really understand the musculature of the pelvic floor, and they can really work with you and use biofeedback techniques to try to help you retrain those muscles to do what you want them to do. And that can sometimes be helpful. So that's how we approach this particular problem. Before we move on and talk about why these GI symptoms are significant in sort of a broader sense, I want to just take a moment and summarize the interplay between the medications that we use to treat the motor symptoms of Parkinson's disease and the GI symptoms. And we've touched on all of these briefly, but nausea and vomiting, as we've discussed, are common side effects of many of the medications that we use to treat the motor symptoms. So sometimes this is our fault because we're giving you medications that are making you feel nauseated. Levodopa and some of the other motor medications also can further slow stomach emptying. So you may have slow stomach emptying from your Parkinson's disease, and then we give you medications that slow it further, and so you get a double whammy in that way. On the flip side, levodopa and some of the other medications can improve other GI symptoms. So drooling, swallowing problems, and the defecatory problems can sometimes get better with optimizing PD motor medications. And so it really is worth a discussion with your neurologist if you're having any of these GI symptoms to figure out what's medication related, what's disease related, and what can we do about it. It's complicated. Okay, so we're going to totally change gears now. We're going to leave our discussion about the clinical symptoms and move into a discussion about why these GI symptoms are interesting and relevant right now from a research perspective. So I mentioned earlier that we know that constipation can sometimes be an early symptom of Parkinson's disease, occurring years before the motor symptoms of the disease. Back in 2006, a German anatomist named Brock published a theory which was very controversial at the time. He had been doing very detailed studies of autopsies in patients with Parkinson's disease across all stages of the disease, and had found that the same pathology the same changes that happen in the cells in the brains of patients with Parkinson's disease can occur in the nerve cells that line the gastrointestinal tract. And he found that those changes in the gastrointestinal nerves were present even in the very early brain stages of Parkinson's disease. And interestingly, even in some healthy people who did not have Parkinson's disease, those same changes were found in the nerve cells that line the GI tract, those Parkinson's-like pathological changes. And so taking that information and sort of running with it, they came up with this theory that perhaps Parkinson's disease actually starts in the GI tract, in the nerves of the GI tract, maybe after we're exposed to something in the environment that triggers that process. And that perhaps then over time, that pathology spreads from the nerve cells that line the GI tract all the way up to the brain along the vagus nerve, which is the nerve that connects the nerve cells in your gut to the nerve cells in your brain. And so at the time that this was published, this was extremely controversial and was sort of kind of a wild idea at the time. It got a lot of attention because it was just, really, for the time, kind of out there. But over the last 10 to 12 years, there's been a steady trickle of evidence that has kind of come in from animal studies and also from human studies to suggest that this might be possible. It's not proven by any stretch of the imagination, but there's a growing body of evidence to suggest that it might be possible. And so there are now some people who are not lunatic fringe anymore, they're actually sort of mainstream, who think that this may very well be true, that Parkinson's disease may start in the GI tract due to something that we're exposed to in our environment, and that starts the process, and that over time it spreads to the brain. And when it does hit the brain, that's when we get our first motor symptoms like tremor or stiffness or slowness. So what is that environmental trigger? That's the big question. And a lot of people have a lot of different ideas about this, and people have studied this, and the bottom line is we don't know. We don't even know that the disease starts in the GI tract at this point. It's still an unproven theory. But the more recent studies have led to a theory that's growing in popularity, that the link between the environment and the pathology in the GI tract has to do with the bacteria that live in our intestines. So we all have over 1 trillion bacteria in our intestines. They're supposed to be there. It's a good thing. They serve a lot of important functions. And actually, an interesting bit of trivia, if you actually weigh that bacteria in our intestines, we all have about 3 pounds worth in our GI tract. So when folks in the last few years have looked at the bacteria that live in the GI tract of people with Parkinson's disease and compared that to people who don't have Parkinson's disease, we have found that there may be some differences there. The studies by different groups have had somewhat conflicting results, but the common theme or thread between all the studies is that Parkinson's patients tend to have more of the bad bacteria that are inflammatory and less of the good bacteria that are considered anti-inflammatory. And so there may be a shift toward this sort of pro-inflammatory state, with the bacteria in the intestines. Interestingly, if you look higher up in the gastrointestinal tract and compare the bugs that live there in Parkinson's patients versus controls, like in the nose or in the mouth, there don't appear to be any significant differences. The real differences seem to be lower down in the colon. So this may be the link that we've been looking for. It's interesting because your gut bacteria are influenced by many things like what you eat, what you drink, medications that you take. And so it is conceivable that this could be the link. Again, by no means proven, but it is an interesting theory that's gaining popularity. And again, there's a sort of growing trickling in of evidence to suggest that that may be possible. So that is all I had planned to talk about today. So at this point, I would be happy to take questions if anybody has them.